familiarize everyone with the machine, but also to make a plan for every one of us of how to systematically and rapidly examine the patient, even in different circumstances, so that you can have simple steps, not just the ones written in books, but also like practical ones, so that you can use in your practice every day. So I have no financial interest to disclose, and also I don't have credit for all of the videos shared in these presentations. Eh, So why do we need a slit lamp while we can diagnose by a pen torch? Actually, the slit lamp is a massive and incredible device that we have. It's just like the stethoscope for the internal medicine doctors. And it's also that it not only gives us diagnosis, but it also gives us a prognosis. The one who attains the skill of slit lamp can go without so many investigations or send the patient for so many ocular investigations to reach a prognosis or eye diagnosis. The first thing we have to know is we have to know our device. I know most of you would be familiar, but here is some reminder of the parts, which is very important. So you know how your device acts in different spaces. Of course, it's so back. You know, like in the old times, it was only uniocular. The binocularity gave it the edge of a three-dimensional image, which is a very great image. So it's so old, backing from the 1800s, and it went through many steps until it reached the part where there is illumination added to it. This made it, the Gallstrad had won the Nobel Prize in Physiology and Medicine for his studies in the optical images. And even everyone would be celebrating the advent of slit lamp. So, what is it actually? So, why do we need actually a slit lamp? It's has an illumination, so it turns everything very bright. It's a magnification device. It's three dimensions, so you can get the depth of things. So you can record stuff if you have a photo slit lamp. So it's a very amazing device in diagnosis and prognosis as well. So the three main components are the illumination system, which is the light source, and the optical microscope itself is the viewing system, and the mechanical one, which makes them interact together. So we all know that this is the chin rest, and this is the head rest, and this is where the eyes should be aligned. The outer canthus would be aligned near the height mark. Why do we have to make sure that the patient rests his head that way so that we get the optimal results? Because we know that it has a moving distance that it can work through. After that and before that, it's not that clear. So the illumination system, there are two illumination systems. Sometimes the illumination comes from above. So this is a Hackstreit device or Hackstreit illumination system. And if the illumination comes from the downside of the downward, so this is the Zeiss system. So both of them have condensing mirrors like +22, plano-convex, and then we have the objective lens, and of course we have the subjective lens where we look through. Of course, the magnification has the microscope has magnification power. If we have this type of slit lamp, this is called the Greenwald magnification, and this one is called the Galilean magnification. Most of us will have more magnification into it. And sometimes many devices which would differ in shapes and size and even place where they place it, but it's all the same maneuver. So if we start here, so this is the viewing device, which is mostly centered in front of the physician, and here is the the lenses. These are plus 10s. You have to make sure that they are your own power, of course, so that you have the optimum vision. Of course, this is the magnification. This is 10 times and this is 16 times. You can switch between them according to your examination part, of course. And this is the illumination part, which can be moved in like 180 degrees. When you are examining the nasal part, you can go through the temporal and vice versa. So why do we need it and when do we need it? We need it in routine examination of the anterior segment. Of course, any differential diagnosis and assessment of the anterior chamber depth, also angle and contact lens examination. Sometimes we add some accessories to add for our further investigation, further examination, like the gonioscopy, fundoscopy, ocular photography, and contact tonometry, like the Goldman, or the laser photocoagulation when you use the contact 3 mirror, bulk mirror. So we have the table type, or table mounted, and the portable. The portable, we use it on bedridden patients or in children or uncooperative patients or patients with back problems, kyphosis or neck problems or obesities. And of course, we have to really have to adjust our posture during examination. So why is that? Because we examine so many patients per day. So we have to feel comfortable, otherwise we will have our own problems or back problems. We have to have a straight back. We have to darken the room a little bit. It's better to be dim, not like totally opaque, but it's dim. It's better for our illumination system. And of course, we can, if the patient is cooperative as a child, we can try and examine him on a slit lamp after some persuasions from us or the nurses. So also the obese patients, we have to try to make them push the seat backwards. This would be a very helpful tip. And lower, so your device, your mechanical device can be work freely. So if you want to buy a slit lamp or you want to examine a slit lamp for your clinic, you should know the dimensions and what's the working distance and the angle between the two pieces, which is 13 degrees for true stereopsis. And we have to know our filters and apertures. So what are the filters? It's like we add those filters to add more clarity to our procedure. So this is the open filter aperture, where it is open for any filter that you can add to your device, while there is a heat absorption or infrared, and the gray filter, red free filter, and the cobalt blue filter. So let's go through them. How do we change them? Like here on the Hackstride, you can change it from this knob, like you can rotate it according to the colors under it. And here on the Zeiss one, you can change it from this knob over here. So the open aperture provides light without heat absorption. Okay, and sometimes they call it, and the fifth one is the empty one. While the heat absorption filters the brightest one and minimizes exposure to excessive light. It's helpful like when the patient has photophobias and cannot open his eyes freely. While the gray filter is ideal for the fundus examination. The gray filter, we would say, it's like the red-free filter. The red-free filter we would use more with which detects minute retinal hemorrhages and microaneurysm. It appears as dark green against light green backgrounds, and it's also very helpful for detection of nerve fiber layer defects in early glaucomas. So while the blue filter, or the cobalt blue, as we all know it, used for the applanations, Goldman applanations, and for the ulcers, erosions, and the Seidel test, but we have to use with it the fluorescein dye or the fluorescein stick. So can we control the width of the slit itself? Yes, actually we can. It can go through from the narrow slit down up to a full wide aperture or the opening of the whole aperture. We can use it to create so many slit widths during examination. But again, we can change the length of the slit. So it can be a very minute short one by 1 millimeters, or it can be the full length of the slit. Again, it can rotate. So the rotation can be vertical, and then it can rotate all around horizontal, can get to the horizontal slit. So we can control the slits. This is how we control the width from the width of the slit. So how do we examine the anterior segment? This is the very famous slide from all the presentations from the illumination techniques. So we'll try to break it down into like the diffuse and the direct and the indirect. Let's try to make it simpler. So the diffuse, we wanted to examine the extraocular surface, like the surface of the eye, the outside. So the beam is so wide. See the beam here? It takes from limbus to limbus. So we don't need to make it a slit. We just open the aperture and we make it. And of course, the eyepiece is in the center. The eyepiece is in the center. So what do we do? I'm sorry. So we try to, the illumination system is 45 degrees to the viewing system, and the eye is totally illuminated. We are looking at the whole eye. So what are we examining actually? We are examining the external system of the eye. So this is like from the eyebrows, the eyelashes, the eyelid margin, and of course all the parts of the cornea, surface of the cornea, the conjunctiva, the caruncle, and of course we should remember to examine the palpebral and the bulbar conjunctiva. So especially if the complaint of the patient would be like grittiness, foreign body sensation, and otherwise. So while we are at this, we should remember to examine the pupillary reflexes. We have to state that we have to be very systematic during a examination so that we do not miss an item. If we miss an item like this, like the relative afferent pupillary defect, we can miss a whole line of differential diagnosis. So if you do not detect do not examine the pupillary reflexes, you should put in mind that it is one of the items that I should examine with using the slit lamp as I am working. Of course, we have a diffuse image of the anterior segment, and this includes the lens, either a phakic one, or like this one is an aphakic subluxated lens, or a posterior chamber IOL, anterior chamber IOL, so you can detect the patient's phakic state. Some physicians don't like to apply fluorescein dye in this stage, but I would prefer to use it in this stage so that I do not miss it later. Because if you do not put in mind that the tear film breakup time, you would miss it during examination. You miss the main trigger of patient's symptoms. As you see here, that the tear breakup time is very early. So we finished the diffuse. Now we're entering into the direct illumination. So what's the difference? The difference is that we are going to narrow the beam. And this takes us into three parts: the optical section, the parallel piped section, and the conical beam. They are written in this order, but I prefer to start with parallel section because it's wide, the diffuse. Then we go to the wide direct illumination, and then we go to the optical section. So what do we use it for? Here's how do we do it. It's like 3 to 4 millimeters, and it is like the illumination system is 45 degrees from the viewing system, and we are looking at the cornea. And here, this is the cornea from the thickness of the cornea, and this is the reflection or the reflection of the light on the iris, and we are examining here the cornea. Now we can take examine it all over the cornea itself, and we can detect all the layers in the cornea. Then we're gonna narrow the beam up to like 1 to 2 millimeter in thickness, and we're gonna take optical sections into the cornea itself. We are looking for what? We are looking for opacities, scars, vessels, and of course, this also gives us an idea about the depth of structures found in it. Like here, there's a corneal foreign body, different forms of cataract, patchy, iris, and corneal opacities like in here. So we can also, by the direct illumination, we can detect KPs on the back of the cornea as well. So what are we looking for and how are we going to do it? It's the same. We are going to be it's always like from 30 to 45 degrees according to the patient and according to the angle of your perception. And then you are going to focus on the cornea and narrow the beam. Here is how to narrow the beam on the cornea. This is the cornea, and this is the iris, and the space between them is the anterior chamber. So the direct illumination can as well the depth perception of the lens itself. How is that? Is that how you move you have to move the focus, the viewing system, and your focus onto the lens while using the optical section. This is the optical section, that's ours. So we go inside, and then if we are here, this is the anterior capsule, and this is the epithelium, and this is here the lens. This is the cortical lens. And then by more focusing, we can get to this is the nucleus, and this is the back of the lens as well. So it is all about just fine-tuning of your movement of the joystick. And instead of using it to just feature or visualize the cornea, you can move it a little bit forward towards the patient to visualize the lens. And of course, when we visualize the lens, we can get to the Lucas classification, and we can classify it very easily according to the if it's nuclear or subcapsular or cortical as well. Here's again a picture, a video of the optical section, and here is the KPs. Can you see the KPs on the back of the cornea? Here's the KPs. What we are seeing with the optical section is all the layers of the cornea. You know, like the endothelium is the only endothelium that can be seen with the eye, the naked eye in the body, and again it's in the epithelium. So it's a very delicate way to detect the depth of layers also as well. So then we are going to go further in to detect the anterior vitreous. So here is more magnification and more going forward towards the patient, okay? And using the same slit lamp. Here the patient has vitreous opacities. Let's see that again. Here's the vitreous opacities within it. That's with the same optical section, but moving the illumination, the viewing system just a little bit forward. We are talking about millimeters forward, which allows us to see more. After that, we've gone through diffuse, and then we decrease it to parapets, and then we are going to the optical section, and now we're going to the conical beam. So the conical beam is that what? It's more useful for what? For examining the transparency of the anterior chamber, looking for either cells, flares, blood into the anterior chamber. So how do we do that? Now we are going to decrease the beam totally, like 1 by 1 millimeter. We are going to depend on something called the Tyndall phenomena. You know, like when the sun comes inside the passes through some dust, you know, and you start to see the dust particles during when a sunbeam comes across. That's exactly what is it when we see the cell and flare in the anterior chamber. Another point is that we see them moving. Why are they moving in that pattern? Like the ones in the anterior part of the cornea in the AC are moving downwards, while the ones near the iris are moving upwards. This is because it's warmer in the back near the iris, and when it reaches the cornea, it is getting colder a little bit, so it goes down. So this is like the convection currents. So that's why it's going upwards and then going backwards. That's why they are moving. This is how we see it. Like here, this is very, very minute cells going through. And let's see, how do we do it? So this is the optic section, the normal optic section. We dim the room, and then we decrease the slit beam totally, and we make the pupil our background. We need a jet black background to see the particles. And here you can see the particles. This is a high magnification. So first of all, you need to shorten the beam, put it on the pupil, and sometimes you can dilate the pupil like this to make it more obvious if it's not visible. And if you're really suspecting some uveitis, even after, especially after cataract extraction, okay, so you need to dim the beam, thin the beam, and dim the lights, and put it on the pupil, and then increase the magnification and look for these moving particles, which can take your prognosis and diagnosis into a new level. So now we're going to indirect illumination. So we've seen everything. So why are we going to do indirect illumination? Indirect illumination, it's because sometimes there are some subtle things to see. You need to see them more. Like the beam is then focused on an area adjacent to the ocular tissue, observed, and this area is observed in shadow. Like we are illuminating an area and looking at another place. What is the purpose? We are looking for a softer illumination to give better definition of structures like vesicles, erosions, vacuoles. So retroillumination, like here, we are putting the beam on the iris by what we are focusing on the cornea over here. We are looking for small scars, corneal vessels, microcysts, vacuoles with the illuminations to make it a high contrast. So we are putting the illumination on the iris, but the focus is on the cornea. So here's the light, but here is the focus. We are focusing on the cornea. We are focusing on the cornea. What's different between the direct and the indirect retroillumination? This one, we use the iris as a background. We use the pupil as a background as well. So you put part of the illumination on the iris and part on the pupil. Here we go. Still, we are using for 45 degrees between the illumination and the viewing system. And We're asking patient, we are focusing here part on the iris and part on the pupil so that we can check the cornea as well. So what's the big deal about it? So why are we using this? If there's a vacuole that is not seen clearly with the other sections here, with the direct and the indirect illumination, would be black in both instances. But if there is an opaque or a pigment or a blood stain on the back of the cornea, so this can be appear as a bright area away from the illumination. Still, so now we are using this is the picture of something. So here's the directly illuminated blood vessels, and here's how they are retro-illuminated. See, this is retro-illumination. And then finally, we are putting the illumination and the viewing system coaxial. Now, every time there is an angle between them. This time we are putting them coaxial so that we want to reflect the red light from the red reflex from the fundus to see details either from the lens, if it's like a dilated fundus, dilated pupil, or like this is the arcase, or this is like an oil droplet in keratoconic eyes. So this is a very perfect maneuver. Of course, in the same way, we can see the slit cuts or the slit defects in the iris or through the iris atrophy, either in exfoliative syndrome, or if there's an iris atrophy secondary to glaucoma or to ischemia or whatever. Here, now it is not the iris slits. The effects are not that obvious, but when we do the trans-illumination, see how it's very obvious. So now we come to one of the least ones that we use actually in our practice. Yet if we use it, we remember to use it, of course, it would add more to our diagnosis. It's called the sclerotic scatter. Okay, so this time we are going to make the light look away from the viewing system. How come? So when we are saying parafocality of the slit lamp has a parafocality. A parafocality is that means that the light falls at the same area as where the physician is looking. So now, no, we need more. We need that that the light would fall on the cornea, and I would take another point to look through. So why do we use it for? We use it for scars and corneal defects and irregularities. So what's the principle behind that? So it's like the same as this sun, and it's falling at a far away point, but its reflections can make it see how the ripples on the water is appearing. This is the same thing, the same intention. So how do we do it? We decouple. What's the decouple? Is that we are making the light fall away from the viewing system. We want the light to fall on the limbus, and we are going to examine the cornea back and forth. So this is the normal situation. We then have to. Now we are changing this situation. That is how we decoupling the light. See, from this knob, we are decoupling. So instead of looking at this point, no, we are trying to put the light at the limbus here. How do we decouple it? Let's go back through this part, through this knob. This is a very, very common question in exams. especially the oral exams, because so many people miss to get the point behind it. So you decouple it, and then you start to look at, once you get the halo around the limbus, so that's where the light is totally scattered in the cornea. This is how it is. You start. So this is the slit lamp, and this is the halo, and you have to look at the cornea, not here, no, across the cornea all over. Here's another one about how to decouple the light system to fall directly on the limbus. And you examine the cornea by itself. And here's how it's falling on the limbus and going through the halo. So the final one we are looking through is the specular illumination. Well, the specular illumination has a story behind it, actually. The specular illumination is like the angle of incidence have to equal the angle of reflection. It is depending on the normal reflection law. Like if you want to see the reflection of a mirror, the angle should be equal between the angle of incidence and the angle of reflection. So here, this is the only examination in the slit lamp where you can change the place of the viewing system and make it like to fall on the same part, and then you have to use monoocular vision to see the refraction or the reflection of light. So if you are examining a mirror, so this will be only one point of reflection. But if the surface is very irregular, you would see multiple diffractions of light from the irregular surface. That's what we are looking for, especially at the endothelial cells. Well, the endothelial cells here, like in this photo, they are magnified highly. Of course, we do not acquire such an image with our slit lamps, but we can get an idea during our examination if this patient is suffering from endothelial defects or not. So this time it is 60 degrees between them, and we are going to change the place of the viewing system. And increase the magnification, and preferably over the pupil, also to get the blackish background. And here's the first Prof Engy image, and then we are looking at the back of this light you are using. Here's the endothelial surface. So some people say, and of course you have to have magnification, high magnification. We are looking at the back of this optical section. Some people say, I do not acquire this image. Actually, when you see the first Prof Engy image, you can move your optic section towards this image and then increase the magnification and move back and forward like very minute millimeters so that you can find an image of the endothelium. So this is the reflection from the front surface. This is the first Prof Engy image, and you use it to move forward to it to acquire the good preview of the endothelium. So what we are looking for the gattata, of course. The gattata is the irregularities in the endothelial system. So why is this important? Because endothelium is irregular. So why don't we send them only for specular microscopy if you're not, you don't have it in your locality? But actually it is because it heightens your skills, your clinical skills, and gives you a prognosis idea, as we said previously. Of course, the specular microscopy would add numbers to your vision, but at least a good physician would know, have an idea even before sending him the patient. So this is an excellent preview, and this is a less better. This is fair, and this is poor when you cannot distinguish between the shape of the cells and you cannot know the shape of the cells. This is a very clear, outlined, hexagonal, minute, well-packed endothelium. And of course, we know that we lose endothelium every year and every decade, and whenever it reaches like 1,000 cells per cubic millimeter, this means it is a very risky surgery. Some people use the 800 cutoff point, while it is better for us to use the 1,000 cutoff point. Of course, specular microscopy is very important before keratoplasties, so that we don't end up with corneal decompensations. So we all are familiar with the retinal drawings, like you can express your findings and with drawings. Actually, this is also possible with corneal pathology. You can express the findings in color coding, like in black, blue, red, and brown, green and yellow. Like you can do like this is a stained area, like this is an ulcer, here's like superficial and deep vessels, and of course if there is pigments, there are edema, and if there's hemorrhage or keratic precipitates, these can all be in your ophthalmological examination sheet. So one more point we don't need to miss is the anterior chamber depth. This is one also of the main things we have to examine during our anterior segment examination by the slit lamp. We don't need to. So there are two methods. Of course, we all are familiar with the pen-torch method. We use it like for crude examination. Here, the Smith method, you set the illumination at 60 degrees as well, and then that beam here is getting horizontal. Finally, we're using the horizontal beam and to the inner side, and then focus between the corneal endothelium and the lens. Then enlarge the beam till cornea and iris reflections just meet in the center, just like this page. And then you have to, if the AC depth, you have to get it into this equation, the slit length plus 10% plus 0.5 in millimeters, and then you get your, if it's occludable or if it is a deep anterior chamber, deep angle as well. While most of us use the peripheral method, which is the Van-Herk method, we narrow the beam at 60 degrees and the beam aligned vertically. Let's take a picture, take a video about it. Here's like around 60. And of course, we go then and try to go to the limbus, focus on the limbus, without decoupling, of course. This is, we are coupled as usual. And we are looking at this image. Here, this is the corneal slit lamp or the optical section, and this is the black area or the empty space in between them, which is the AC, and this is the iris reflection from the iris, of course. So we are going to compare this thickness with the black or the empty space behind it, which is the AC. And of course, it would be grade 1, which is like grade 4 is the open angle. It's like they are equal in size. If it's like half, it's grade 3. If it's like 1/4, like the AC darkish area is 1/4 of the optic section, so it's a grade 2. And if it's less than 1/4, so this is grade 1. We cannot leave out the applanation tonometry. So the applanation tonometry is a common place step in slit lamp examination. We have to use fluorescein dye, and of course we have to use the cobalt blue, so we are changing, and we have to make it a slit beam. and of course after putting anesthetic. And here we are using a uniocular vision also as well. So to make it more obvious, we are looking for the inner uh, touch of the two half circles, of course. These are the skills that should be uh, taught here. One more thing to remember, that's called tilting. See, there is a knob that you can tilt in your device here so that you can decrease the amount of light entering the eye, especially in photophobic patients. So, are you confused yet or not? Let's have a quiz. So, what do you think this is? Which method of illumination is used in this one? This one. Here we can see like this is dislocated, misplaced posterior chamber IOL, and we can see the reflex. So it's more like it's a retroillumination. Okay, we are looking at the retroillumination of the fundus. So what do you think this one is? This is an optic section here, and this is the iris, of course, and this is high magnification. You can see it's a high magnification. And here's the focus is on the posterior part of the cornea. So this is more probably a specular examination for the iris. This is one is so easy actually, because you know that we are here looking at a sclerotic patient sclerotic examination with the light falling down on the limbus and having this glow. Once you get this glow, you know that the light would be traveling across the whole cornea, and you can see the very, very minute details that can not be seen by the regular optic section. And this one, this is the very easy one. Here's the optic section, the normal optic section. Okay, and this is the iris here was cut by the pupil. So if I want to make things easier, I would go like this in my head. I would start with, I would go with diffuse, then I would decrease it a little bit. This is a paralleled, and then I'll go with the optic section, and then I will decrease the beam so much to get the conical beam, and then I would do the indirect illumination and along with the direct, because they are both the same in the same maneuver. You can do the direct and the indirect in the same maneuver, okay? And then you can do the retro illumination. Finally, you get to the specular and the sclerotic, which don't take so much time actually. But you can get out with this. If we are saying why is, let's say that we are going to have some questions like what's parafocality of the Slitlamp? The normal answer would be like it is like the way that light and the viewing system coincide on the same spot. So when do we decouple the light and the viewing system? We couple it in the sclerotic examination. When do we use monoocular viewing system, like in applanation tonometer and in specular examination? I hope this was helpful. Happy to receive any questions. Thank you.
Thank you, Dr. Engy, for your interesting lecture. Now I ask my friends to join us by questions. If any one of our colleagues in the Zoom meeting want to ask Dr. Engy about anything about this interesting lecture, anyone can speak. anyone want to ask a question can ask Dr. Engy about this lecture. So I want to ask you, Dr. Engy, about something in slit lamp examination. Uh, can you tell us about the importance of slit lamp examination in examining the dry eye disorders in the eye? Now we can find that there is many devices in the market which can evaluate dry eye degree. But I think that slit lamp examination is still the main tool for evaluation dry eye. Can you tell us about this topic?
This is very true. Slit lamp is the one and only, or the first line of diagnosis. I think if you examine your patient well, you will detect most of the parameters that are examined by other devices meant for dry eye. Although they offer you some quantitative numbers, but actually, when you are examining the patient from the diffuse way, you can see first the frothy tear film in the diffuse examination, and then you can examine the lids, looking for and the lid margins, looking for blepharitis, and you can see the openings of the meibomian gland, like the pouting of the meibomian glands, and even like you can see that they are inspissated with and blocked by dry secretions, and you can see also if there is trichiasis or if there is like infection accompanying them, and also you can do the fluorescein dye testing, the fluorescein dye test, and also the tear breakup time and the Schirmer test. Most of them are done in an outpatient setting, not needing any investigation, which can lead to a very, very definite diagnosis of dry eye.
Angie, this is a good answer about slit lamp evaluation for dry eye disorders. I want to ask you about dry eye evaluation of anterior segment inflammation, like in cases of anterior uveitis, and how we can use slit lamp to evaluate uveitis, especially inflammation of the anterior segment for these cases.
Anterior uveitis is a problematic entity because it can be so subtle. It can be so simple, and it can be overlooked and missed. So if you do not put it in your mind and have a high index of suspicion during your examination, you will miss it. So sometimes, even if you start like by looking at the eye and seeing the patient that is a little bit photophobic with with regular epithelium, so you have to start to say why he is that photophobic. Okay, and then start to look for the subtle findings that can be like very, very minute keratotic precipitates, or like there's a very minute irregularity in the pupil with early mudding of the iris, or like of course if it go for the cells and flare. The cells and flare can be very early and very minute, really minute, especially the ones post-operative, in post-operative cataract extraction. So many people miss the anterior uveitis part during examination. You have to put it in your mind so that you can look for it after surgery.
Some of our friends ask a question for you, Dr. Engy. Are you using only fluorescein or different coloring in the different situations?
Actually, we are using fluorescein dye only. The rose bengal has a very stinging effect on the patient, and most of our patients are dry eye patients, so they are already overstimulated. So we are not using it, and also because it's very rare in Egypt. But I know other localities that they use it. But when it was available in Egypt, it was really not the best choice for patients. So we depend on fluorescein dye, which is, in my opinion, it gives us a full account of all the defects that we need to explore.
Hey, Dr. Engy, thank you for this nice presentation, and I hope
Please,
that our friends,
I
any
have
one of
question.
our friends, okay,
I have
go ahead.
question, please.
Okay, go ahead.
Hello,
Hi,
hello. I wanna thank. I have. I wanna thank Professor Engy for this interesting lecture.
thank you.
My question is it possible to perform the optic section in case of diffuse corneal opacification, especially in the context of ulcer and epithelial defect?
I think this is the main idea of the optical section. That's the main idea, so that you want to know how deep is your ulcer. Is it only like in the anterior parts of the cornea? Is it epithelial only? Is it going through the stroma? It's the main job of optical section, as I know it. And of course, in the same way in the opacities, if you are going to examine the opacity and you want to have a crude idea about the optical, the depth of the opacity, so you are going to use the optical section. It will give you a very good idea if it is superficial or if it's like going through the stroma or even like going back to the endothelia. It is a very, very reliable method, as I believe.
Thank you. Thank you.
You're welcome.
One of our friends asked a question, can give find of rose bengal stain? I can't understand the question, but it is about rose bengal stain, Dr. Engy.
Well, rose bengal is, I've worked with it in some localities, but not in Egypt, but I worked with it. And the main advantage over the fluorescein dye would be like it also sustains the disease, not only the dead areas or the denuded areas. It's also and it has they use it there in conjunctival staining as well. It's very good in conjunctival staining in cases of dry eye. This is the overhead in rose bengal. Otherwise, as we do not find it in our locality, we can go with the fluorescein dye.